So that is why this morning I'm introducing Dr. Christina Maslach, who's recognized as the authority on workplace burnout. And she's conducted some of the landmark research in this area. She developed a research tool called the Maslach Inventory, which allows a compilation of how to judge this particular problem in a very detailed scientific way so conclusions can be made. She's developed strategies for prevention. She will be sharing her knowledge and experience on this subject with us this morning for our benefit. Her academic credentials include an undergraduate degree from Harvard, Radcliffe, and a doctorate from Stanford. She's a tenured full professor at the University of California at Berkeley, and she's authored numerous papers and books. So please, this morning, let us welcome Dr. Maslach. Please give her a warm welcome.
Okay, well, thank you very much for inviting me. I have to admit that I've always been, as an early child, from an early childhood, a night owl and not a early morning bird. And my mom sometimes would call the school and say, you know, she's not feeling so well today and just let me sleep. I say, Mom, you did that? And I said, yes. So at any rate, with talking with physicians, you always schedule things really early in the morning, which is not exactly my peak period, but I hope I'll be doing well today and sharing with you what it is that we, and this means colleagues from all over the world actually, who are working on the topic of job burnout, and trying to summarize for you what it is we know, what are still the questions, and where we hope to go with this. So defining burnout, and this is an important thing because the term gets used widely and loosely and sometimes often incorrectly, so that it becomes a word that covers a lot of ground, and are we really talking the same language? Basically, what burnout is, as I discovered through research starting back in the 70s, is that it's this prolonged response, it's an experience you're having to chronic situational stressors on the job. And I want to underline chronic. What it means is this is the everyday stuff that you're dealing with. It's not an occasional emergency or an occasional crisis, but this is the stuff that is there a lot of the time and essentially begins to erode your capacity and ability to feel that you're doing well, that you're accomplishing the things you need to do, that you're feeling good about, all of this kind of thing. So chronic stressors. And basically what we have found in the research is that there are sort of three acting dimensions to this experience. One is the exhaustion, and this is, as you know, the individual stress response. So it is in the stress ballpark. And we see the same kinds of physiological changes, the same kinds of poor health outcomes, et cetera, that we see with any kind of exhaustion stress response. But it's not just exhaustion. If it were, we would just call it exhaustion. We wouldn't tack on another label to it. For me, personally, the important aspect of it is what we talk about as cynicism, this more negative, hostile, depersonalizing response to the work, to other people. Could be patients, could be colleagues, could be other kinds of things. This is where a lot of the meaning of the work lies, and when this begins to go, and we begin to have this more, take this job and shove it, as Johnny Paycheck used to sing a lot. For me, what you begin to see, and I'm always interested not just in what people think and feel, but how they behave, what they're doing. What we see is that people begin to shift to doing the bare minimum rather than their very best. How can I get through and get everything done, at least enough? Not maybe terrific, but at least enough to still get out of here and still get a paycheck. And then the third one, third dimension, and I have to say this is one that gets ignored a lot, although I want to make an argument that it's important, and I'll get to that later. And that is that it begins to have a negative evaluation of yourself, in the sense of it's not just about the job and the people and why am I doing this and I should have done something else or whatever. You're beginning to feel maybe I'm not good enough. Maybe I made a mistake. I'm not particularly proud sometimes of, of what I do and how I've carried out the job. And when we begin to see, this could be, if you look at it over time, a potential marker for things that could lead to, you know, anxiety or depression. And as people have been talking about, although I haven't studied this, suicidal ideation. So it's these three dimensions. There's different patterns. You can be higher or lower on it. But these are the things that make up really the cluster of the experience that we're talking about as job burnout. Whoops. There we go. Sorry. When I started out doing research on burnout, I didn't know about burnout. I actually discovered it from doing interviews and talking with people, and they were describing something. And after a while, I was seeing a pattern and sort of began asking, do you talk about this? Oh no, stigma, would never say this. There was no name for it. Eventually, somebody said, well, we call it burnout. And then when I would end my interviews with, okay, does this detached concern, is it burnout? Yes, that's it. That's the word, you know, that captures it. So we've been studying healthcare professionals for a long time, and so have many others. It's probably the one profession that has more work on burnout than any others, but we're seeing it all over, and particularly these days, a lot in high-tech companies. So you're not alone. But at any rate, this is just the summary of some of the outcomes that are linked to burnout. This is why we care about burnout. It's not just you're having a bad day, but because of burnout, the quality of patient care, independently, patients rating how they're feeling about how they're being treated goes down. There's more medical errors. Dysfunctional relationships with colleagues, not working well in terms of support, trust, mentorship, et cetera. Greater risk of substance abuse, depression, suicidal, I mentioned that before. And what we're seeing now in a lot of surveys that other people are doing is there a greater intention to leave or not go in or not even recommend a medical profession. A recent survey asked physicians throughout North America if they would recommend their occupation to their own child, or someone you cared about, and only 1 in 10 said yes. Well, that's a concern, about what is going on here, that instead of that old song about mama, don't raise your, kid to be a cowboy, we're saying don't raise him or her to be a doctor. And so I think there are some, larger issues that are linked in here that we need to look at. This is a question I always get asked. Well, is it that it's just the person? They're not really that good, they're not competent, they're weak, they're da-da-da-da. Or is it a problem of the situation? And the answer is most people talk about it as though it's a problem of people, of individuals. What it means is they ignore the situation. And actually, it's the wrong question. It's an and question. It should be, rather than or. It's not either or. It's both. And I have a quote here that some of you may have come across. It gets cited a lot. And this is done by a lot of the team of researchers at Mayo. The fact that almost 1 in 2 U.S. physicians has symptoms of burnout implies that the origins of this problem are rooted in the environment and care delivery system rather than in the personal characteristics of a few susceptible individuals. So this is Tate Shanafels and all of his people. Now, they're talking about 50%. Sometimes you'll see numbers like 70%. And they're talking about symptoms of burnout as though it's a disease. And I'll come back to that point later because I think that's part of the issue of where we're getting into some miscommunication or misunderstandings about what burnout is about. So my argument is that it involves both person and situation. People are operating in a context with all kinds of constraints and rewards and whatever, and to not look at that and acknowledge what you need to do is a problem. So you can talk about burned out people, but in many cases, you need to look at what's going on in the job environment and all the flames that are licking at your heels as you're running on that treadmill to try and get everything done. We really need to kind of take a new, fresh approach on this. So rethink the problem. Again, burnout, trying to keep in mind those 3 dimensions. Here's what burnout is not. I could probably add a few more, but I'll just do these. It is not only one of those three dimensions. And they're being called symptoms, particularly within healthcare, and saying if you have one of those, like if you're just exhausted, that's enough to call you burnout. Well, no, it's not. Burnout is trying to get the whole negative package. It could be a step toward or, a risk factor. It is not a psychological disease or a clinical deficit. And there are people who are arguing that burnout is just depression. And in fact, all medical journals should just strip burnout from the title and replace depression, depression, depression. 50% of you are depressed, or 70% of you are depressed. The evidence shows no. They are different kinds of things, but it is true, and we've got longitudinal research, not of mine, but of colleagues, who, following people over time, show that having a issue with burnout, sort of further upstream, if you will, can lead to, be a step on a path toward later depression or anxiety. But it's not the same thing. It is not diagnosed, here's the medicalization going on, it's not diagnosed by a cutoff score. I see a lot of things where people are saying, oh, there's this score, they're in the upper third, or they're in the middle third, or whatever, and it's by this. No, nobody. No clinical research has ever established that kind of diagnosis, if you will. It also gets used a lot as a synonym for all kinds of other problems. And this is, in some sense, the fact that the imagery and the word and the term is so accessible and people, yes, kind of gravitate and used to it is a plus. It's also got a downside, which means anything can be fit into there. So I don't know if you've noticed lately, but burnout gets attached to a lot of other things all the time. Midlife crisis burnout. I'm thinking, okay, we need to add that term. Or we're talking about now, big articles out there all the time, millennial burnout, or you can pick a lot of stuff and add it. But it adds to the difficulty sometimes about talking about it because there's different meanings. This last point that I wanted to make here is that, in some sense, burnout is not the important end state that you need to look at. It is a warning sign. It's telling you about other things that need to be addressed. In that sense, as I said here, it's a red flag. It should be viewed as, if you're having more people who are dealing with this, what is this telling you about what's going on? Actually, I was talking with someone just the other day, and they came up with a different analogy, which let me share with you and see if you think it's a better one than the red flag. I actually think it is. And that is, burnout is like the canary in the coal mine. What it's doing is like when you put the canary down into the coal mine, that is a sign, is this a safe enough environment for people, for the miners to go into? If the canary is not doing well, it's saying there's something wrong. This is a toxic environment. People are not going to, they're going to struggle, they're not going to do well, they could even die in the mine. And what do you do? What you do not do is try to make the canary tough, resilient, really strong, really big, tough bird that can take anything, No, the idea is fix the toxicity in the workplace so that when the bird and everybody goes back, you're doing fine. And I'm going to come back to that because there's a tendency to focus, as I said before, on people and fixing the bird, so to speak, rather than fixing the mine or the workplace and actually misreading what that signal is all about. Pressing too hard here. Yeah, here we go. Light touch. All right. The Maslach Burnout Inventory is the measure that was developed in the 70s. It's been used in all kinds of research. And it assesses those three dimensions. It uses a frequency rating. So we're saying not do you agree, disagree, but we're saying how often do you feel these various kinds of things in terms of the statement. And the scores are not added into a single score because different patterns could yield the same total. You need to sort of look at all of them. You look at the patterns, you look at the profiles, and I'll show you those in a moment. And I mention this because what I see happening, and I certainly see it happening in a lot of the healthcare work, research about this is there is a tendency to want to simplify it, make it one item rather than actually a scale measure, which you need to do, to only look at one dimension rather than all three, use a cutoff score and make it sort of this bimodal, yes, no, you're burned out, you're not. And this is a problem. It's being used as a diagnostic tool for a presumed disease, and it's a research measure. It's a different kind of thing. So the simplification of burnout, I'll give you a few examples. It's just exhaustion, that's all it is. People are just working too hard, they're tired, and they can't get up well and so forth. And say, no, I mean, if it were just exhaustion, you would call it exhaustion and only focus on that. No value added. It ignores other factors besides, what makes people feel overworked. It's just depression. I mentioned this before. It's a very flawed argument based on, and I won't go through the research, but it's on research which basically takes two, measures of burnout and exhaustion, which are both highly loaded with exhaustion items, and says, see, they look the same. It's not. It's a separate step in a path towards depression, can be. It's diagnosed by a cutoff. Again, no clinical research has done that. Yeah, okay. Oh, sorry. Demographic disparities. I was asked to talk about this, and this often comes up when I'm asked to talk on medical CME kind of things. And basically, at the moment, the research doesn't find a lot of major demographic differences. We could have a whole lecture on why not and what the difficulties are of doing this kind of work. But in it, we tend to see, in terms people ask about gender, and that's why I've used some examples here, we tend to see men scoring slightly higher on cynicism, women slightly higher on the exhaustion. But the problem, the biggest problem, is that these demographic differences, or markers, are confounded with other things. So in other words, you cannot separate out gender, age, etc., from the fact that they might be confounded with the type of specialty or the type of occupation. It used to be that if you did men and women in healthcare, you would be comparing physicians and nurses. So what has to do with sex or gender as opposed to what has to do with the occupation? So are they major differences? No, we have not been able to find them. Other people haven't. I think it's worth looking at, but the other problem is that it's easy to toss in a question about check off which group you are without any idea of why you're looking at it and what other evidence you might need to use to find an answer to those questions. So there's a lot we don't know yet, but so far it's not been a huge issue. How many healthcare workers are burned out? What I thought I'd share with you today is a distribution from some of my colleagues, and this combines, at the time, this was the 20,000 healthcare workers across both Europe and North America. They have many more now, but the same point comes out. And I'm using just the exhaustion distribution, but it's true for all three dimensions of burnout. And if you look at it, you'll see it is a skewed distribution. It's not one of those normal kinds of things. It is skewed towards the positive end. 0 means almost never do I feel this way. 1 is maybe a few times a year, okay? So at some point, what is the critical point at which you say we're talking about burnout? And one could argue maybe that those who score several times a week or every day, these are the people who are having more of a problem. And those, in general, tend to be on the far end, and it's around 10%. Maybe a little less in the past. But it's not just on exhaustion. You have to also look at what are their scores on cynicism and inefficacy, and what does that really look like compared to the others. So what I want to share with you is what are the 5 main profiles of work experience, not just burnout, that we find in the research, and you can sort of give you a context for the burnout. So with burnout, people are having 3 high negative scores, which would mean they're in that, endpoint range of, several times a week or more, is what I'm feeling on this. But there's more. There are other ones. There's one that we're calling disengaged, and they only have 1 high negative score, and it happens to be on the cynicism. It's on this, negative reaction to the job. Everything else looks moderate, average, or low, but it's one high. We then also have a pattern we're calling overextended, and the one high negative score here is exhaustion. So everything else is, reasonable, but exhaustion is negative. We have another one, which is the high score is on the inefficacy. You're pretty okay on exhaustion and cynicism, but on inefficacy, you're really feeling negatively about you and yourself and what's going on. And this tends, as I said before, to get understudied a lot, especially in the healthcare research. And finally, we get the group that has no negative scores. They're all positive. They're not having a problem with any of those three things. And those are the group that we talk about as engaged. So whenever we look at any kind of sample, say, of physicians or others, we can analyze the profiles and look at these 5 different patterns. And this is data that we got just recently, my colleague Michael Leiter and I. These are healthcare workers, several thousand of them. This is from one of the first studies we did. But you can see how these cluster, so that you can see the burnout is the blue dots in this case. They're high on everything. The engaged are the red ones, all clustered on the positive end. And then you can see the disengaged, overextended, and ineffective in between. This is another sample, did just recently of physicians. And what we did was, again, look at the 5 profiles. And I just thought because I'll get back to the other data in this group too in a minute. But what you can see here is that the burnout group is, do I have it? Yeah, is this one right here. It's not 50%, it is 15%. Now 15 is higher than the usual 7 to 9 to 10%. It is going up. But it's not the huge, thing that we're hearing about. Twice as many people over here are engaged. They're doing pretty okay. It's not to say they don't have their troubles and whatever, but they're not showing negative signs of burnout. And that's not atypical. Now, if you remember, I showed you that quote that said 1 or more symptoms. Basically, what's happening there is they're taking the people who score high in all 3, because at least they have more, 1 or more, but they're also adding in this group, which is the high cynicism, and they're adding in this group, which is the high exhaustion, right? Just 1, not the whole 3. And lo and behold, what you're getting at that point is at least half the sample. If they were to add in this group, which is the high inefficacy, and they usually don't because they don't measure it, but if you did, you'd be talking about basically 70% of the sample. Calling all of that burnout, when really the problem that we really identify is here, makes it difficult to sort of understand what we're really dealing with here. Do we know that these people with 1 symptom only are recovering from, or are moving towards, or are just getting stuck in this one different kind of pattern? Could be. And I'll get back in a minute to show you some other data about this. So basically what I want to sort of, before going into that data, just to say here, the problem of unhealthy jobs. This again is the situational context. And this is not something new. This is not something we should be ignoring so much. We scholars in a lot of different fields, it's not about my own research, but we have known this for a long time, and there is tons and tons of data. Various job conditions are highly stressful and toxic in the sense of socially, and psychologically toxic. We know this, and it comes from long working hours, high demands, job insecurity, lack of control, low social support, work, family. There's a lot you can put in there. There's a few examples. We know that. We also know that those job conditions, those stressors, pose a danger to the employee's well-being. We've known that for a long time, and there's tons of data. So, unnecessary deaths, healthcare costs, lower life expectancy, more working years lost, greater risk of burnout, depression, and more. The other thing, which is now, when people doing analyses of all of this, is to say, often the thing is we have to work like this in order to enhance productivity. This is what's going to make us work better, harder, do more. And we need to do it because of the economic bottom line. And last year, Jeff Pfeffer from the Stanford Business School did an analysis of all of these data. He's been doing it for years, and came out with this book saying, the evidence does not support the conclusion that it enhances productivity or the bottom line. So his book, Dying for a Paycheck, How Modern Management Harms Employee Health and Company Performance, is the summary of all of that work and that data, and it's worth taking a look at, because the mantra that I keep hearing in many, many different kinds of workplaces today is, well, folks, we have to do more with less. And it's a kind of math that is not making sense and is, I think, fitting into all of this. And, we don't have enough doctors for the patients, et cetera. We're seeing this in all kinds of other industries as well. So if there's one slide you remember when you leave here, it should be this one. And that is what we have found. I'm summarizing here. There are 6 areas in terms of how well people and the job conditions kind of fit or match or are in balance that are predictive of burnout, or in a positive way are predictive of engagement. So those 6 are these. And I'm just going to mention them briefly, and I'll show you some more data around them. They're not organized in order of importance. They're organized in order of what people think is important. The first one is workload. Everybody's saying, if you're stressed, if you're burned out, you're working too hard, you've got too much to do. And in fact, workload and exhaustion are clearly linked. So there's some evidence of that. But surprisingly, we often find that workload for burnout is not as major a problem as people would think. There are other things, and what's important about this is that it gives you other paths into thinking about what can we do to improve how we're doing healthcare. So the second one is control, and basically this means that you have some appropriate level of autonomy and choice and discretion in terms of how to get things done, how to make the best happen. Reward, obviously people think of this in terms of things like salary and benefits and perks and so forth, but what we're finding is that that positive feedback, which is what reward is especially important when it is social, when it's recognition, when people notice what you do and are thankful, grateful, pat you on the back saying, you did it, this is great, thank you so much for coming to my help, whatever it happens to be. So the recognition, social rewards, turning out to be very important. Community refers to the workplace community, not the larger community in this case, but the workplace. These are the people that you come in contact with. Your colleagues, your boss, the people you supervise, your patients, their families, all kinds of other people who you are working on your team on this. And are those relationships one that are working well? Or is there a lack of support, distrust, competitiveness, people trying to throw each other under the bus, conflict that never gets resolved? A lot of ways in which your colleagues and the people that are around you are your most important source of support and protection against burnout. And when those begin to go sour and go south, you've got some major problems. And I'm hearing a lot more about this, not just in healthcare, but in a lot of places, about socially toxic workplaces. I think I'm good at what I do, I like working it, but God, get me out of this clinic. Or, can I work from home? No, I can't, what can I do? So this is an important area, again, to be thinking about. Fifth area has to do with fairness. Fairness means whatever the rules are, whatever the policy, whatever the practice, that they are fairly administered in terms of who gets a new opportunity, who gets a promotion, the office with the window, et cetera. So when things are not done fairly, where it's who you know rather than what you do, when there's glass ceilings, when there's discrimination and bias in terms of how things are carried out, fairness. And this leads a lot to the cynicism part of burnout when it's a problem. And finally, values. This is meaning. This is why we do this. This is why we care. This is why we think this is an important thing that I can contribute while I'm on this earth. And this is an important thing for any work, to feel that it makes a difference and you can feel proud of it. You tell other people, about what you're doing, and there's something really important in there. And again, when that goes, that is really critical. So those 6 areas is not only, these are where sources that we've been finding of burnout come from, but they give you 6 paths to try and do something about it. So you may not be able to change workload, but you could change some other issues with regard to reward, or maybe it's community or something like that. So if there's a mismatch, these are the kinds of things we're seeing as examples. Demand overload, lack of control, insufficient reward, breakdown, the socially toxic community, absence of fairness, value conflicts. This is where you're being asked to do things that you think are unethical or wrong, or you're ending up violating your own sense of this is what my patient deserves and I can't do it, and how do I feel about it? The more we see of these problems in these 6 areas, the greater the risk of burnout. So how do we turn some of these around? Let me go back to the data I just showed you of this big survey of physicians. And as you can see again, we asked them we measured these 6 areas, plus another one. They wanted to answer questions about administration, so we put that in as well. And here's what it looks like. So I'm giving you this as an example. What you can see on this is that here's the burnout group, right? 15% of that sample. They are being compared on a baseline for the normative baseline for physicians. So they're being compared within their own occupation. And what you can see with the most burned out group, negative on all 3, is that nothing is going really well. They're looking worse than average on all 6 of those areas, 7 with the administration counted in. But if you look over here at the opposite end, that's the 29%, twice as much, people engaged. They're not showing the negative scores. They're not showing necessarily highly positive, but there's not a presence of burnout. And they're looking, relative to the baseline, pretty good. But that's not all there is. It's not burnout, or burnout engaged. There's a sizable chunk of people who are all in those middle profiles. Now, one of the things that is happening is that when people are using only exhaustion to measure burnout, and there's getting people who are scoring only high on exhaustion, it's this profile right here, okay, the middle one. And they're often saying, well, if they're high on exhaustion is burnout, they're high burnout. Well, you can look at this on the other data. They're not the same. They're not having the same kind of work experiences and work challenges as the burnout group. They have one big, major issue, and that is workload. That is their big negative score that you're seeing. Way too much to do, not enough time to do it in, not enough resources to get the job done well. Otherwise, they're looking just sort of average, typical, not some good, some better. The ones that are looking a little bit more burned out is this group. And their one negative score is cynicism. Okay, so it's when they're beginning to have that negative feeling about the work, they're losing the meaning of why they're doing this, it's getting too much, etc. They're not showing a real problem with workload. They're just average, typical, but everything else is beginning to look bad. And then finally, let me point out the one that gets unstudied, which is a substantial group in itself. This is the feeling professionally ineffective group. And they're just kind of average, typical. In fact, workload is not a huge issue for them. But the interesting thing about it is if you think about what can we do to actually make things a little bit more positive, improve this group might be easier to move in a more positive direction than trying to do something about that. That's going to be a tougher case. And so in a sense, what all of the data on the profiles, if you look at it in more depth here, suggests the possibility that the solution that you're going to use for these people might be different than what you do for somebody over here. So this notion of a one-size-fits-all intervention, I have never, ever seen any evidence that it works because it's It's changing stuff, which is always a little bit more stressful for people, but it's not necessarily tackling what the problems are. So at any rate, this kind of thing, looking at those 6 areas, gives you a better handle into what we might be doing. Okay, rethinking the solutions. As I mentioned before, there is a high tendency now to focus on the individual only. What do we do to fix you and you and you? And you better take care of yourself. And here are ways you can take care of yourself. Get more sleep, eat healthy, all these kind of things. The implicit message is that, not only it's your fault, there's something wrong with you, and you are the one who have to fix what's wrong with yourself, but it basically lets the workplace and the situation off the hook. Nothing wrong with the job, that is what it is, kind of thing. So that's a message that I really worry about. The other thing is that, keep pressing the wrong button, hold on. Sorry, here we go. That a lot of these coping strategies, and there are a lot of them out there. There are workshops, there are retreats, there are, all kinds of things that are done, and they're helping you cope with stressors. Be healthy, meditate, exercise, do all these good things. I'm in favor of those good things. That's great. The problem is it doesn't change the situation that is causing the problem. It's making you stronger again, like that canary. It makes you run faster on that treadmill and do it for longer periods of time, but it's not changing what is actually, it's giving the working conditions a free pass. And so this is why I think you're seeing now, and maybe, I don't know if you've seen it recently, but a backlash, certainly within healthcare, saying, stop saying that burnout is about meditating and taking, lavender oil and getting a massage, and they're criticizing the use of burnout and saying it's been co-opted to mean it is your problem and so forth, and they're talking about moral injury. Call it what it is. It's not burnout. Burnout, you're kind of thing. So I think this is the kind of argument that they're trying to make there. So what will success look like? I have talked with a lot of different medical groups and organizations, and their solution, which they come to me and say, I'm sure you'll be happy about this. We're going to use your measure. We're going to measure people, and then we're going to measure them again in a year or two. And I'm thinking, why? What are you going to do about it? It's kind of like the scores will get better, and then we'll have less burnout, and it will be good. And I'm saying the burnout scores are not going to change unless you do something about some of those chronic stressors, unless you begin to try and figure out that sort of thing. So what are the important outcomes? Not just burnout scores. That's that mediating thing. You care about quality of care with patients. You are concerned about people's well-being and ability to do a good job and all of that other stuff. That's what you should be looking at, and not the scores alone. The scores are measuring the canary, but you need to focus on the workplace mind that the canary is going into. And I must say, just as a little thing, that the MBI scores get used in ways that are antithetical to research values. So I will get phone calls, or I will get grabbed at conferences, or I'll get emails that go like this. So I'm emailing you, I'm a medical student, I'm a resident, I'm a whatever, and I just want you to know, burnout lady, that I have to fill out your measure every year, kind of thing. And I want you, and say, well, okay, thank you, tell me more. And they'll say, I just want you to know that I lie. I don't tell the truth on those things. And I say, really, tell me more. And it's like, it's not confidential, it's not anonymous, they know who I am. And if I fill this out pretty soon and really say what's happening and how I'm feeling, I'm going to get a tap on my shoulder by somebody who says, honey, you're having a problem. You should go see counseling, see a psychiatrist for what your issue is. Are they doing anything about my patient load? No. Are they doing anything about, fill in the blank? No. But I am now a marked person. So I'm not going to say what's really happening. I'm going to say what looks good, because I don't want to risk that letter of recommendation, for my promotion, for my placement, residency, et cetera. And the other thing is people say, I fill this out every year. What do they do with that? It doesn't show anything that's happened. Have they listened? No. The other thing is I've heard from physicians in some places where they say they've had to fill this out and the scores are then posted outside, the clinic. I see a lot of head nodding. You've seen this, okay? And it's kind of like, it's like shaming, So what are we trying to do here? Understand what is the problem that we want to solve, but we're still saying, your fault, your fault. Here's the good guys, here's the bad ones over here. They can't take it. This is not particularly helpful. And they're doing that with my measure, which is not great. And it's a research measure, So we need a more systemic framework. We need to be thinking about it in terms of like health, safety kinds of things. It's in terms of the context, the group, the unit, whatever. Okay, so is there a different way we can go about it? And I just want to say, if you take those 6 areas, you can start thinking about what might be a more positive goal we could move towards. How do we get a more sustainable workload? Could be high at times, but how do you have time to recover, do other kind of things? How do you build in appropriate choice and control over how you do your work or the improvements we make? How do we do a better job of recognition and reward for work well done? How do we build a more supportive workplace community? If there was one I would pick, it would be this one. How do we build in a sense of fairness, which includes things like respect, social justice, how we do things, whatever the framework is? And how do we really promote those clear values in meaningful work? Now, these are, you could think of maybe some other possibilities for some of those outcomes. Those are just ones I'm proposing. But it might be that rather than think about the burnout, think about where do we want to move towards and how in any of these 6 areas could we begin to take a few steps. Small steps are better as a starting point than a big overall one-size-fits-all kind of thing. And get people involved. So you're getting input from the people who have to carry this out and will live with the change. And often that's not done. I'm not going to spend a lot of time on the case studies of checkups, but we've done this, for example, with a lot of organizations, not in healthcare, but we assess on this. We get everybody participating. They start a process. For example, one organization turned out the huge issue across the organization was fairness. Usually the CEO says it'll be workload and it'll be reward. Not always. In fact, that's not me. Fairness was however things are done here. And in this case, for example, one of them was an award, Distinguished Service Award. And then people said, what, you mean we need to give more money for that? I said, no, they said it was unfair. The people who got it are not the people who deserved it. So you had an unfair process. So they, for a year, changed their processes. And after a while, the whole fairness issue began to drop. So they were making a change in one area that clearly meant a lot to people. This one is work that is done by my colleagues, primarily in Canada, also the United States, now in Australia. And it's been focusing primarily on nurses, but it's in healthcare settings. It's called CREW, Civility, Respect, Engagement at Work. It's a 6-month team process, 1 hour a week, and trying to get everybody sort of involved. And it builds, it changes, it begins to say, what are the things that we're doing that are, and it was the nurses themselves who suggested this, by the way. It's how we treat each other, which is the biggest problem with burnout. It's the incivility, it's the bullying, it's the rolling the eyes. Can you make them stop rolling their eyes? And, this process really worked. The burnout rates went down. He's been following them now for right after the 6-month process, 6 months later, a year and a half later. More civility, less burnout, less absenteeism. The nurses are not, disappearing from work, they're showing up more often. So there are possibilities to begin to take one of those 6 areas and begin to make some positive changes. So basically, the strategies really need to focus on both the person and the situation. It's not enough to say to people, go take care of yourself and then you'll be okay. But it's really trying to find out what is it that we, as a team, as a unit, as a group, et cetera, can do to make this a better place. And I have found that there are a lot of things that can be done that are inexpensive, relatively easy, under the radar. You don't have to ask for permission from the higher up, but it can be done within your own sort of more immediate group that makes a difference. And early detection prevention, trying to make this better so that you don't get people experiencing that extreme state of burnout, because that's a hard one at that point to cure, or, if you're going to use medical terms, or turn around. So, conclusions. It is more of a chronic situational problem than an individual problem. It's both what the person brings, but it really, really have to pay attention to what is the setting, the environment, the conditions under which they are going to be doing their work. And you've got to be looking at both, because it's those chronic situational stressors that are really more of the source of the problem. Improvements in social work environments can help prevent burnout and build engagement. So we're seeing that. That's certainly one of the 6, and sort of goes through a number of the 6. But what we're finding is, in a lot of organizations these days, is that there is a shredding and pulling apart of the social network, of our relationships with people, of knowing who to go to if you have a problem, feeling you can trust someone to talk about, I'm kind of stuck, could I get some advice, rather than feeling, if I do that, I am marked as not good, as weak, as whatever. And so I shut up and I don't say, and don't go and get the kind of, teaching, mentorship, help, advice, etc. If this is one of our best resources, and we know from years and years of work in psychology that being socially connected at work, at home, neighborhood, family, friends, whatever, one of the best things for mental health and well-being. We should not be our own worst enemies in the workplace, and how can we begin to make some changes in that? And it requires reciprocal relationships between colleagues. So it's not about you get better, you get better. It's about more of a we than a me, kind of, how do we figure out a way in which we can make this a better place for us, that we feel really good about it? How do we encourage people to come in, and so forth? And those 6 areas that I mentioned of job person fit, that can be the diagnostic tool that begins to identify what's working well, but where are there areas where we should do improvements? So like that organization that discovered that fairness was the issue, rather than let's give, people want a better salary, but we don't have enough money. You could do other things that actually make a difference. And the other thing that happens, we find, is that when people work on one of these areas in a smaller way, and make a difference, it builds a huge amount of optimism and hope that we could do some more, that other things could happen. It begins to be a step in building a better kind of climate and culture, and one that we feel good about. So it is, when I started this research, because I stumbled on it by accident, quite honestly. I didn't know what I was looking at until people were telling me. And I had no idea that decades later, it's this issue that is becoming such a more major kind of thing. But I do think what we've learned about it over the years can point us in directions of how do we create better environments, a healthy work environments where people thrive rather than get beaten down by burnout. So good luck on all of your work, and I wish you much engagement and really low burnout. Thank you.
There'll be time for a few questions, if you like. Take 5 minutes for questions.
Over here.
Can you cite some literature, some papers that we might look at about healthcare organizations who have implemented an anti-burnout strategy that has worked, so that we could get ideas?
Yeah. The work I do spans a lot of different organizations. So if you want to focus more on healthcare, then the work by Michael Leiter on the crew things is one, but the other would be the people from Mayo, Tate Shanafelt, who is now the Chief Wellness Officer at Stanford Medical. He and his team of people have written lots of different articles and papers focusing really specifically on issues within healthcare. And so, for example, you'll find them talking about, in terms of interventions, they use the phrase, the pebbles in our shoes. So when I say making small steps, they're saying, what are the things that actually drive us a little crazy? They're not often big things, they are the little everyday things that just drag you down, interfere, et cetera. And they've done work with medical students, residents, in hospitals, and obviously they're focusing on that. So there's a whole string of colleagues who have worked with him, so that would be the easiest way to try and find all of those. I will just add one point, though, is that they have come up with ideas and proposals for various things, big, small, whatever, on what could be done. And the challenge is how those are implemented. In other words, you can have a good idea, and you can do it in a way that people are saying, are you nuts? So one example, and I'll tell the sort of a little bit of a joke on Tate, as I was meeting with him, one of the things that came out in one of the papers was, again, trying to build better relationships between people who normally don't have time to get together, know each other, on the job and so forth. And it was all about the hospital or, whatever, paying for the physicians to get a little group together and go out for dinner, and have a chance to have time together and a nice setting and so forth. And I was at a meeting with Tate, and a woman came in, who's, leading physician. She was on part of our interview panel, and she's saying, this is the most crazy thing. I just got this email, saying, okay, here's what you got to do. You've got to find a bunch of people, pick a restaurant, go out, eat, etc., have a good time, come back, here's where you submit your bill to get reimbursed. And she said, I don't have the time to do this. Why am I being told that, da-da-da-da-da-da? So it could be a good idea to implement it as, thou shalt, this is from the paper, do it, without taking into account how you might do it in a different way, or when you had the appropriate time, or, trying to feel, this is where the top-down without getting bottom-up input is the problem. And so the implementation is the issue. But look at that work. I think that would be best for healthcare. Sorry, longer answer than I thought.
A similar question, have you found a model health organization that's already doing a bang-up job and has low
I wish I
burnout
knew
rates?
so that I could say, do what they do, The problem for someone like me is that unless I'm going around and actually visiting and observing and living it and sort of feeling, what's going on, how would I know? And I would know because people will write about it. They will do something that shares that so that people get here's what we've been trying and it's actually kind of working. And that doesn't happen very much. So I don't know if there's tons of stuff out there that might be great, if there are certain organizations that are better models or not. I rely on people like you and other people in different organizations, or people in tech organizations, or people in teaching, in schools or whatever, to tell me, and I invite them, let me know, where do you think something is going on that is really, making a difference? Because I would love to be able to pass it on, share it, broadcast it. But quite honestly, I don't know. And what I have heard, and I get this sort of anecdotally, so again, is that things sometimes are tried, but there's never any follow-up or evaluation like, did it work? Did it make sort of a difference, but if you tweaked it, it might actually be better? Did they ever try it again? Did they do something else? What? And I guess about the only message consistently that I get from those sort of anecdotal reports is that there is a tendency to go for external solutions that are brought in rather than trying to do some more homegrown things that fit us better in some way. And it's not to knock it, but there's a huge industry out there of people coming in and doing coaching and doing seminars and doing wellness and retreats and, you know, tons and tons and tons of stuff. But like the example I was just giving, can you plant it and it really grows and thrives given your conditions and what's happening here? And that's where we don't always, you know, do that. And as I said, there are things that can be done. I mean, I remember about a year ago, I was talking with physicians at a set of pediatric hospitals back east, and they said, okay, Dr. Maslach, we're setting up a meeting with the physicians now. They're very busy. They may not be able to come, da-da-da-da-da. We've put out lunch. We hope we'll, you know. So I said, that's fine, you know, whatever. So people start coming in, and what happens? Oh my God, haven't seen you in months. Big hug, you know, how's your kid doing? Did you ever go to the Warriors game you talked about? I mean, you know, and it was like this big thing, like you know, I'm looking, and they're saying, Dr. Maslach, should we start? And I said, no, let it go for a while. And then the first thing was, you guys don't get together very often, right? And you don't see each other, and that was the big thing. No, we don't. We don't see each other in the cafeteria anymore. We're working in our offices. We have different schedules. We're scattered in buildings. We don't have, you know, all of this kind of thing. And here was this opportunity that came up where this was important. So it was like, how can you do that just on your own within smaller units? You know, find other ways in which those little moments of positive, you know, fun, happiness, sharing, you know, things. This is how you get to know the people you can turn to, who you can trust. It's because you've established that kind of relationship. You know, and there are times when all of us, you know, I could really use another voice, another input on that. So there are things like that. I think, you know, with the Shanafelt, the Mayo people, they have a lot of ideas on that. But back to your question, if you ever have something you can point to on a small scale, big scale, whatever, that says, this is really making a difference. I would love to be able to help, you know, share that, because everybody's asking that same question. Everybody wants to know. And if I could do it, it would be great. Anyway, okay. How are we doing on time?
Yeah, let's cut it off there so we can keep a little bit on schedule. Again, Dr. Maslach agreed to be around on the break, so if those of you have questions first, we'll be happy to discuss them with you and carry out. Thank you so much.
Thank you so much, too.